What I want to sort of start off my presentation with is as to how accidentally we discovered the syndrome of hypogonadotropic hypogonadism, which basically means low testosterone, as you explained earlier, due to changes in the hypothalamus and the pituitary. And this happened following the arrival of Viagra. And when Viagra arrived in 1997, urologists began to prescribe Viagra like there was no tomorrow. And then they found a whole lot of diabetics who did not respond to Viagra in terms of erectile dysfunction. And these patients were obviously then referred to an endocrinologist, i.e. me, and I then systematically looked at these patients and found that they were all of these diabetics with erectile dysfunction who were non-responsive to Viagra had low testosterone levels. And then around that time, Sandeep Dinsa, who's also a speaker later in the day, you just go back. Yeah. Joined me as a fellow. And then together, we did this study published in 2004, showing for the first time, as you look at the panels on the left, that both total and free testosterone concentrations in the diabetics, type 2 diabetics, are low. And then we also looked at gonadotropins, LH and FSH, which too were low. So therefore, the syndrome originated in the hypothalamus and the pituitary and was not due to a primary testicular defect. So we have stuck to the term hypogonadotropic hypogonadism on that basis. The other thing that emerged from these data was that the quality of control of diabetes, as reflected in glycated hemoglobin, HbA1c, or in the duration of diabetes, were not related to the low testosterone. The only correlation they had, next slide, was with body weight. So you can see as the body weight increases, testosterone concentrations come down. So therefore, then that led us to do the first detailed, large study on obese patients who did not have diabetes. Next slide. And in this, you can see that in the non-diabetic obese, the frequency of hypogonadism is of the order of around 25%, whereas that in the diabetics is of the order of 35%, or let's say 1/3 in one case and 1/4 in the other. So therefore, that observation made us conclude that obesity and type 2 diabetes were probably the most important causes of the hypogonadal state in the male, because this, on the basis of the prevalence of obesity and diabetes, led to an increase in hypogonadal males in the United States by 20 million, most of whom are still need to be diagnosed and to be treated appropriately. Next slide. This then led to a large NIH grant to us to investigate the mechanisms underlying the entire state and as to what happened with our patients who we treated with testosterone over a period of 6 months. What we found on clamp studies was that the hypogonadal type 2 diabetic patients had an extra insulin resistance of the order of around 35%. And with it, what was interesting was that when we did fat biopsies in these patients, we were able to show that insulin signal transduction, insulin signaling at the cellular level was diminished at 4 different levels. And keep this in mind, although this is technical, but it's important that at 4 different levels, insulin signaling is diminished if you have a low testosterone. Next slide. In addition, there's another pathway which is dependent on which mediates the good effects of exercise and the anti-diabetic drug metformin and this particular enzyme is AMP kinase, and that too is diminished in these patients. Next slide. Now, when we give testosterone to these patients over a period of 6 months, this was the study that we did, you can see that the testosterone concentrations were steadily increased during this period, whereas the testosterone concentrations in the placebo group that was not treated were unchanged. Next slide. And then the other interesting thing is that during this 6-month period, the total lean body mass, i.e. the muscle mass, increased significantly, while the total fat mass diminished. And this is very important. And this is one of the things that one has to emphasize when we talk about overall quality of life and so on, that the muscle mass is dependent upon testosterone and increases under the influence of testosterone, whereas adipose tissue, fatty tissue, diminishes. And this issue will be discussed later on by Farid Saad when he talks about the long-term effects of testosterone. Next slide. And then here we can see that following testosterone treatment, the insulin resistance that I talked about, the 35% extra insulin resistance diminishes. In other words, testosterone is an insulin sensitizer. This was really very, very important observation in this area, shown at the cellular and molecular level. And then you can see that insulin sensitivity increased, as I mentioned. Next slide. And then with it, at all those 4 sites at which there was a deficiency in insulin signaling at the molecular level, they were all replenished to the normal baseline. So clearly, testosterone is a very powerful metabolic hormone, as Dr. Paresh mentioned earlier. And one of the most important actions is at the level of insulin action. And that part will be discussed later. And then we come to next slide. Next slide, let's go on. And then we analyze further at the molecular level as to why the muscle increases in size. And there is a very important factor called FGF2, fibroblast growth factor 2, which mediates the growth of the muscle. And this is the very first human study in that, because till then it has only been shown in mice. And we demonstrated that FGF2 increases with testosterone. And with it, another factor which is known to increase muscle mass, IGF-1, also increases with testosterone. Next slide. And then with it, the receptor to the FGF2 also increases with testosterone therapy. So these were very important factors that we demonstrated. And in addition, another important, interesting observation was that myostatin, which is a molecule that suppresses muscle growth, causes muscle atrophy, was suppressed by testosterone. So testosterone in multiple ways, metabolic ways, really enhancing muscle growth, insulin sensitivity, and a potential anti-diabetic effect. Next slide. And here, what we've demonstrated here in a recent study published last year, showing that body weight is a major determinant of testosterone concentrations. So what you're looking at here is a set of data of patients with from the Teen Lab study, and these were patients between the ages of 14 and 20, adolescents, morbidly obese, who were subjected to bariatric surgery. And you can see in the yellow and the orange lines, as the weight falls, the testosterone levels increase. So clearly a beautiful correlation with body weight. And then in addition, you got the bonus here, that those patients who regained weight, as in the red line, they also again lowered their testosterone concentrations. So obesity is a prime determinant of low testosterone concentrations. And if you can't fight obesity as such with bariatric surgery, because it's complicated and not commonly, some patients are not commonly subjected to it, then you have to look at other ways of reducing body weight. But with it, I've also mentioned to you that there is also the issue of rising testosterone or testosterone levels after testosterone therapy, and a fall in adiposity, fall in adipose tissue, increase in muscle tissue. Next slide. So then we go on to the T4DM study from Australia. And this was also mentioned in the passing by Dr. Paresh, but I just want to mention here that these were patients either with pre-diabetes or with early type 2 diabetes. And when they were given testosterone therapy along with lifestyle program changes, they had some very interesting effects. Next slide. And you had a decrease in the outcome measures with prevalence of type 2 diabetes in these early type 2 diabetics coming down by more than 41% in comparison with the placebo arm. So clearly, it has an anti-diabetic effect. Next slide. And so I would also sort of just sum up that issue by saying that even the pre-diabetics reversed in a significant fashion. So let me then conclude by saying that the hypogonadal state is a part, almost an integral part, of having type 2 diabetes and being obese. You need to measure testosterone in every one of those patients. And then testosterone administration reverses the extra insulin resistance that these patients have, and that can reflect in reversal of diabetes and pre-diabetes. So these issues have got to be considered in mind when we think about testosterone. Clearly, it is a mediator of good health, good life, and lifestyle. And I've not spent time on that aspect, but I see that every day in my clinic. And the last little thing that I want to mention, that 2 years ago, we published a case report on narcolepsy, a patient going off to sleep, obese patient going off to sleep while talking to his wife, while talking to his relatives. And when we found that he was hypogonadal, testosterone therapy reversed the narcolepsy. So immense differences caused by testosterone therapy. Thank you very much for your time and attention.